Introduction to Urinalysis, Chapter 2. So we're going to take a step away from all the safety and things and start learning about what urinalysis really means. Why do we do urinalysis? There's a lot of reasons. It's not just urinalysis. We're also going to look at things like synovial fluid and spinal fluid, seminal fluid, anything that you could possibly think of that's a fluid that comes out of the human body as well. So let's get started. Going way back to the Egyptians, we could see that they were testing urine because of the hieroglyphics that were on the cave walls. They would look at the color, the clarity, the odor, the viscosity, which is how thick it is, or even the sweetness of it. Somebody had a sweet tasting urine, it probably meant they were diabetic, right? In the 5th century BC, Hippocrates wrote the uroscopy book, which we'll talk about on the next slide. In 1694, we moved to boiling the urine to determine if there was protein present. And if you're ever wondering where the word piss came from, you can thank the charlatans for that one. And 17th century, they invented the microscope. It didn't become part of a routine physical until 1827. So when we look at Hippocrates and what he wrote, it's interesting that it's so basic. So when he looked at it, he could see that when there's a reddish sediment, the disease is going to last a really long time, but they will recover. If there's clouds floating in the urine and they're white, it's a bad meeting if it's black. So I can imagine black urine would be good, or would be bad. So as long as urine is yellow and thin, this signifies that the disease is still in an early stage. When the urine remains like this for a long period, it is to be feared that the patient will not resist much longer before the disease reaches the critical point. So if they are really sick and their urine gets really thin and watery, it probably doesn't exist, it probably meant that they were going to die. So they just looked at the very basics. Is it red? Is it yellow? Is it thick? Is it black? Very, very simple, right? So he did look at a few of these different things when it came to looking at urine. All right, so what is the importance? Well, it's a readily available and very easy to collect specimen. We can tell a lot of information about the patient. It's very inexpensive, and it assesses many metabolic functions. The Clinical Laboratory Standards Institute has urinalysis defined as the testing of urine with procedures commonly performed in an expeditious, reliable, safe, and cost-effective manner. It means we can get it really quick. There's a lot of reasons to perform. It can aid in disease diagnosis, it can screen for asymptomatic diseases, and monitor disease progresses, and also therapy effectiveness when they're being treated for something. The body makes urine as an ultrafiltrate of plasma. So all of your plasma is filtered through the kidneys, and it removes waste products essentially. It's able to remove the bad stuff and put the good stuff back in, okay, in layman's terms. The kidney converts approximately 170,000 mils of filtered plasma a day. So that's about 85 of these 2-liter Diet Coke bottles. I did the math on that. You can do the math and double check that, but I think I have it right. The average daily urine output is about 1,200 mils. And if you look at this Diet Coke bottle here, this big 2-liter, it's a little more than half of that. Depending on how much you drink, obviously that's going to be different. The urine composition is 95% water and 5% solutes. Solutes are everything else that could possibly be in there. Salts, electrolytes, waste products like urea, etc. Those are all solutes, okay? The solute variations can be from diet, activity, metabolism, any endocrine issues, and body position as well, depending if you're laying down, standing up. The major organic solute is urea. Urea comes from the breakdown products of protein and amino acid breakdowns. Your body breaks down proteins, uses them. Then you have leftover amino acids. Those amino acids create a lot of ammonia. Okay, so amino acid, ammonia, they kind of sound alike, right? Because a breakdown product of an amino acid is ammonia. Ammonia is very toxic to the body. If you've ever cleaned your house with ammonia cleaning solution, it is very strong and noxious. You don't want it close to your face. You don't want that floating around in your bloodstream either. So your liver does a really nice job of packaging it into something called urea, where it can safely travel to the kidney and be excreted. We also see inorganic chlorides, sodium, and potassium. Okay, so those are electrolytes that we do see in the body. We do need those, right? But you don't need too much of one or the other. So the kidneys can do a really nice job of getting rid of it if there's too much, or reabsorbing it if it needs more. Urea and creatinine identify fluid as a urine. So there's been times where a doctor is doing surgery and they open someone up and there's a big pile of fluid. They don't know, is it urine or is it a different type of fluid? If they send it to the lab and we do a urine and creat on it, we can tell it's a urine. Okay? If it's very, very low, it's probably a serous fluid or some type of a transudate or exudate type of fluid that came from another area of the body, but it's not urine. It can also contain cells, casts, crystals, mucus, bacteria, all these wonderful things that we are going to talk about as we move through the next, 15 weeks of this course. So there's a lot of things to be learned. Oh, I learned not to use my mouse to switch slides. Okay. Urine volume is determined by the body's state of hydration. As you know, if you don't drink a lot of water, you become dehydrated and you don't pee as much, right? So this is influenced by your fluid intake, any fluid loss, your antidiuretic hormone, which you may have heard about from anatomy and physiology class, and excretion of large amounts of dissolved solids, such as glucose. So here's a urine chart that I found, and sometimes you see this in like locker rooms, like boys and girls locker rooms in high schools, that they want them to keep their urine a little bit more on the light side rather than the dark side because that means they're well hydrated, okay? The usual daily volume is 1,200 to 1,500 mils, which is a little over half of that 2-liter bottle, but the normal range can go anywhere from 600 to 2,000. To give you any indication of how much 600 is, that's like 2 cans of soda. 1 can of soda is like 350 mils. So 2 of those would be about 600 mils, 700. We have some definitions that you have to be familiar with. Oliguria is a decrease in urine output. So less than 1 mil per kilogram per hour in infants, less than 0.5 mil per kilogram per hour in children, or less than 400 mils per day in adults. You really want to memorize mainly the adult range. So less than 400, but greater than 100 mils would be oliguria. So it's a decrease. It's not complete cessation of urine flow like anuria. Anuria is a complete cessation, means there's pretty much no flow at all. It's usually less than 100 mils a day. This can be from severe kidney damage or decreased renal blood flow. Nocturia is increased urine excretion at night, normally 2 to 3 times more than during the day. Polyuria, greater than about 2,000 liters, or 2.5 liters a day, 2,000 mils. So those 2-liter bottles of soda, if you're getting 1 of those to 1.5 of those a day, that is polyuria, meaning that you're going quite a bit. There's a few things that could cause that. Diabetes, diabetes insipidus, or just drinking a ton of water. So what is the difference between diabetes mellitus and diabetes insipidus? Diabetes mellitus is an increased volume caused by the need to excrete the excess glucose not reabsorbed by the ultrafiltrate. The patients are very thirsty. We call that polydipsia, and the urine appears dilute with a high specific gravity. So that seems like it doesn't make sense. Their urine is very clear, and yet it's got a high specific gravity. High specific gravity means there's a lot of dissolved solutes in it. That is caused from having a lot of glucose. So their body will increase the urine volume. So that when you have a high glucose. Diabetes insipidus is not caused by having a lack of insulin or high glucose. This one is caused by the decreased production or function of antidiuretic hormone. This causes a decreased reabsorption from the water as an ultrafiltrate. This is usually a pituitary dysfunction. The urine is very dilute, and the patients also experience polydipsia. With a diabetes insipidus, it's very easily fixed with giving them a shot of ADH. You give them a shot of that, all of a sudden they're better. Otherwise, they drink and drink and drink and pee themselves to death. If this is not fixed, they will die. Diabetes mellitus is similar, but they need insulin. Okay, diabetes insipidus needs ADH. The reason I have SIP on the highlighted in red is because think of sipping a ton of water. They'll be very, very thirsty and they'll pee a lot. So diabetes insipidus has the ADH issue. With specimen collection, we always want to wear gloves when we're working with urine. You want to use clean, dry, leak-proof containers. You want to have disposable, wide-mouth, flat-bottom containers with screw caps. You don't want them to be very narrow so they tip over easily. Clear containers that have at least 50 mils of capacity. Ideally sterile. because if they're not sterile, we can't do a culture on them if they have an infection and we want to see what kind of bacteria there is. We need at least 12 mils to do a urine dipstick and microurinalysis. There are adhesive bags for pediatrics. I'll pull these out when we're on campus. And large plastic containers for 24-hour specimens, or like these giant 2,000 ml or 2-liter jugs, essentially, that a patient collects urine in for 24 hours straight. Labeling is just as imperative in urinalysis as it is in hematology. We need the patient's name or an identification number or date of birth, the date and the time. Not always a collector's initials, because a lot of times the patient's collecting it, but you want to make sure you have that other information on there. You want to place the on the container, not the lid, okay? Because you don't want to take the lid off, set it down, take a lid off of a couple containers, and you get the lids mixed up. Requisition form must accompany a specimen if it's coming from outside the lab. It must match the label. The time of receipt should be put on the requisition so we know how long it had been from when it was collected till we received it. If it's been a long time, that specimen's not going to be any good. Other information is a type of specimen. We'll talk about these in a little bit here, but is it clean catch? Is it suprapubic? Is it catheterized? Those things can give us some good information and let the physician know too what they're dealing with. We may reject a urine specimen if it's not labeled, if the labels and requisition forms don't match. If the specimens are contaminated with feces or toilet paper, you'd be surprised at the things people throw in the urine container. Sometimes the little wipes that we hand out with it, I've seen people shove all of the wipes in the container. Sometimes you'd think that you wouldn't have to tell patients that, but it's something that you may want to add to a instruction sheet because some of them just think that's what they have to do. Containers with contaminated exteriors. Okay, so if it's full of feces or something, you'd be amazed what we get. Specimens with insufficient quantity. Specimens that have been improperly transported. Okay, so maybe it's supposed to be refrigerated and you receive it on a hot summer day at 100 degrees. It's been sitting in the back of a transport van. And labs have written policies for the rejection of specimens. If you do reject it, you do have to fill out a report. Specimen integrity is important. Urine isn't good for very long. So test within 2 hours of collection. After that, if it sits, things don't look the same. If there's any cells, they kind of start to die off and look pretty abnormal where you can't really tell what they are. If it can't be tested within 2 hours, it needs to be refrigerated or chemically preserved if it is a test that would require chemical preservation. Most problems are caused by bacterial multiplication. So if there is any bacteria at all, even normal skin contamination, if it sits, that's going to multiply and cause all kinds of nasties. And you may be reporting an increased bacterial count to the physician that maybe didn't exist just because it sat. Okay, so you want to make sure that you're on top of it. I would say definitely try and test a urine as fast as you can after it's collected. So if it sits, you may see color changes. It may get more turbid, it get more cloudy. The pH will go up, the nitrates might go up depending on what kind of bacteria are there. There's going to be more bacteria and it's going to stink to high heaven. Okay, so you really want to make sure it's done right away because then it's not so bad. What'll decrease is glucose. Okay, that's going to go down the cells and bacteria will use that up. The ketones will just kind of disintegrate, which we'll talk about what those are moving forward. Bilirubin's going to degrade from being exposed to light. Urobilinogen's going to break down. Your RBCs are probably going to lyse. WBCs are going to die and start to disintegrate, and your casts aren't going to look like casts anymore. So those are things that it can be impacted just from sitting. So as you can see, definitely test it as soon as possible. So here are some things that we can look for in an unpreserved urine. So if a urine sits for a long period of time, these are the things that can happen. So what's going to happen to the color? Well, it can become darker due to oxidation or reduction of certain metabolites. The clarity is going to become decreased, which means it's going to get cloudy. We're going to see bacterial growth and a precipitation of amorphous material. Amorphous material is normal. It's obnoxious is what it is. So these crystals that are normal are just because of the pH of the urine are going to start to kind of form, and it's going to make it look like somebody poured Pepto-Bismol in your urine. And it's really unfortunate because then you can't see anything. It's really difficult. So like, again, test it right away. The odor might increase. Okay, you're going to have increased bacteria causing the breakdown of urea to ammonia. So it's going to reek. You're going to open the container and it's going to knock you on your tuchus. pH is going to increase due to the increase of the ammonia and extra bacteria. We're going to lose CO2 in there too. Glucose is going to decrease because bacteria is going to use it. Ketones from the bacterial metabolism, bilirubin due to light, urobilinogen, it's going to oxidize, nitrate, depending, it may increase if there is nitrate producing bacteria. Everything else is going to decrease or multiply. So I went over this the last slide very, very quickly, but this is a nice chart form to help you out. Trichomonas is an interesting one. This one is a STD that if we do a fresh urine, we'll find it. If it sits for 2 hours in a refrigerator, we're not going to see it. Okay, so that one is a really, really great one to do if they're very symptomatic, to do as soon as they collect it, because it'll rinse off into the urine and we'll see it. But if it dies, it's going to be the same size as a white cell, and we're not really going to know it's there. So we need to refrigerate it at 2 to 8 degrees Celsius. This will decrease the bacterial growth. And it must return to room temperature for chemical testing. So if it's ice cold, what's going to happen when we dip our dipstick in there? There's chemical reactions that happen on those in those little pads on the dipstick. And you know, as you learned in chemistry, I'm sure that decrease in temperature slows down a chemical reaction. So you may get inaccurate readings on there because the reactions are not able to complete themselves. We need a chemical preservative if it's going to sit for too long. So bactericidal is definitely ideal. We see this container over here, something I haven't worked with very often, but maybe if there's a clinic out in the middle of nowhere and the specimens have to travel to a reference lab, they may use something like this. Commercial transport tubes are available as seen here, but they must be compatible with the tests. So refrigeration, the advantages is it doesn't interfere with chemical tests, but the disadvantages is it causes things to precipitate, which means we get more of that cloudiness. It prevents bacterial growth for 24 hours, so that's nice. Boric acid is something that we might add that prevents bacterial growth and metabolism. It interferes with drug and hormone analysis, and it keeps the pH at about 6. So that's good for urine culture transport. They come in like a little gray top container. Formalin is good for sediment preservative or formaldehyde. It acts as a reducing agent that interferes with chemical tests, so we couldn't do a dipstick on it, but it will preserve cells in casts so that we can see it. Sodium fluoride is a good preservative for drug analysis. Okay, it is also inhibits reagent strip for glucose, blood, and leukocytes. So we certainly could not do a urinalysis on that, but only for drug analysis. Commercial preservative tablets are convenient when refrigeration is not possible. Okay, so this might cause interference. It's not something that I've seen very often. Urine collection kits contain a collection cup, straw, and culture and sensitivity preservative tube. So you have a kit that could come with everything you need. And light gray and gray culture and sensitivity tubes. These are the ones that have the boric acid that I just talked about. We put it in these little tubes to transport to the microbiology department. That way, it will keep the specimen stable for 48 hours to allow travel time for culture setup. So the bacteria isn't continuing to grow and grow and grow. Or in the refrigerator, it won't kill it off as easily. So here's where we're going to talk about the different types of specimens. The composition of urine depends on the patient's metabolic state and the timing and the procedure used for the collection. The time, length, and method of collection and the patient's dietary and medicinal intake is important. And the patients must be instructed when special collection techniques are required. And the couple that I'm thinking of is a clean catch midstream and maybe a 24-hour collection. Those require some special collection techniques. The first one is a random specimen. This is the most common type received. It's a routine screening. Can be collected any time throughout the day. Dietary intake and physical activity could alter results, so that's just something the physician would need to be aware of. And patient may need to collect an additional specimen under controlled conditions if need be. If they want to do a first morning one or something like that, the doctor would have to specify. The next one is a first morning specimen. This one's easy. It's just as it sounds. It's the patient is in a very basal state. It's used for orthostatic protein conformation and urine pregnancy tests. Reason being is some people have a lot of protein upon laying down and standing up. This would pick that up. That's orthostatic protein conformation. Urine pregnancy tests, if a urine has been in the patient for a long period of time, you have a better chance of picking up a test result. It's more concentrated, so if there is protein present or anything else, you're more apt to pick it up than a more diluted one. And the patient should collect immediately upon rising and deliver to the lab within 2 hours and keep it refrigerated. Fasting specimen for urine is very strange. The only thing I could see this for is if somebody might be screened for diabetes. So the second specimen is voided and collected in the after the first morning specimen. It does not contain metabolites from the evening meal, and it's recommended for glucose monitoring. Something this is very rare. 24-hour time specimen is a lot more common. So with this one, we want to look for things that would be excreted over a period of time throughout a whole entire 24 hours. Things like catecholamines, maybe creatinine, which tests for kidney function, certain electrolytes to see how well the body is reabsorbing and secreting those. The patient must remain adequately hydrated. Patient must be instructed on the procedure for collecting the time specimen. We're going to cover these in class. And the concentration of a substance in a particular period must be calculated from the urine volume produced during that time. So depending on how much urine we have in the container and how long it took, it tells the doctor how many mils per minute or how many milligrams per hour, something like that, is involved in that calculation. And we'll be doing a lot of those moving forward. It must be mixed thoroughly and the volume accurately measured and recorded. So in order to do the calculation to see how many mils per minute were excreted along with how many milligrams per deciliter there are, we have to mix it and we pour off a small amount to test, but we have to know the whole amount. If they need more than a 2-liter jug, and sometimes they do, sometimes we get 2, they have to be mixed together. Additives should not interfere with the test, so sometimes it'll need an additive, sometimes it won't. We just have to look it up and see. The 24-hour specimens are needed for measuring substances with a diurnal variation as well. So if you have a test that may be lower in the morning or higher in the evening, such as cortisol, urine cortisol. Shorter time specimens can be done as well. I've seen 12-hour time specimens, but the timing needs to be very accurate or the results won't be. Timing is critical. A 2-hour postprandial specimen, this means that a patient goes before eating a routine meal. So they eat a meal and then they collect the next specimen 2 hours after finishing the meal. This monitors insulin therapy. The results can be compared with a fasting urine specimen and blood test results. Again, this is pretty rare. In most cases, we do more blood testing on these diabetic patients, but you may come across this at some point in the future. So just know that a fasting urine and 2-hour postprandial urine may be done. But in most cases, it's going to be a fasting blood glucose and a fasting, and a 2-hour postprandial blood glucose. We also have glucose tolerant specimens. Those of you that have kids, which is probably not very many of you actually, we do a glucose tolerance test to see if a patient is diabetic or if they have gestational diabetes when they're pregnant. You've probably heard of people who have to get a glucose tolerance test done when they're, 4 or 5 months pregnant to see if they have gestational diabetes. So this is an option for collection with a blood glucose tolerance test. It's not frequently done, but again, they have the patient drink a bunch of glucose, and then they would test the blood and or the urine to see how well they were able to metabolize that or if it remained in their bloodstream. The next one is catheterized specimens. This is where a sterile specimen is collected from the bladder with a hollow tube. The most common test for this is a bacterial culture, or people that are unable to go to the bathroom on their own for a variety of reasons. Okay, maybe they're in a wheelchair. Maybe they are elderly, maybe they have inflamed prostate, maybe they are in a coma, maybe they're in ICU, maybe they're immobile. There's just all kinds of reasons where a patient would not be able to go on their own, and this would be how they would get the urine from the patient. Midstream clean catch urine is the most common method. It's an alternative to the catheterized specimen. So it's less contaminated than a routine collection. It provides the patient with a cleansing material, or those wipes that I mentioned, and a container. They're told to not touch or contaminate the inside of the container. They're completely free of contamination for culture. Oh, sorry, I gotta go back. This one, they would void the first part of the urine and then just collect the mid portion of the urine. Okay, so you go for a few seconds and then collect the mid portion. This would make sure there isn't any contamination from the outside of the body that ends up in the urine. The next one is suprapubic aspiration. This one is definitely completely free of contamination. This one's for culture and cytology. I see this one done more often on newborn babies. Okay, so it's an external introduction of the needle. So they put a needle through the stomach into the bladder and actually suck the urine out. So again, pediatrics, babies, infants, NICU babies, things like that, to see if there is a urine culture or a urine infection. A prostatitis specimen, this is where they're looking for if a patient has a prostate inflammation. So they do what's called the 3-glass collection. I have never gotten one of these, but if you work for a urologist in a urologist clinic or something, you'd probably see these. So the first container 1, the first urine is passed. Container 2 is the middle part of the urine. Then what they would do is they would massage the prostate to obtain prostatic fluid, and then container 3 would get the remaining urine and fluid. They do cultures on all 3 specimens and examine 1 and 3 for WBCs. If there's more WBCs in container 3 than container 1, it would be positive for prostatitis. In a lot of cases, what I see in the clinics nowadays is they'll just do 1 collection, and they'll go based off of the patient's symptoms on how they treat. So if they think they do have prostatitis, they would treat the prostatitis based on the fact that they're having prostate inflammation type of symptoms, rather than trying to go through all of this. But you may come across it. Again, I just repeated all of this, but there'll be a higher WBC in 3 than 1. Okay. Specimen 2 is a control for bladder or kidney infection. If they all have the same amount, then obviously they have a bladder infection. They can also do a pre and post massage test, so they can do a specimen, then they do a massage specimen after that. So rather than doing 3, they might just do a pre and a post. Again, prostatitis is indicated by a culture. So pediatric specimens can be tricky if they don't want to do a suprapubic aspiration, which can obviously be very uncomfortable for the child. I wouldn't want somebody putting a needle through my stomach either. What we can do is we can put this little clear, soft plastic bag. It's this little horseshoe looking thing is sticky. So what we do is we just clean the patient and we put this sticky bag on the baby. And usually what works really slick is if they need a urine specimen and their blood drawn, put this on and then draw their blood, because the blood draw is going to make them pee because they're going to be screaming their head off. So that's usually what I recommend the nurses if they have to do both. Like, don't do this and wait. Have us draw the baby's blood while they're wearing this, because it will definitely get some urine out of them. We monitor the bag frequently. It's a sterile bag, and it's questionable. I mean, they do what they can to clean as best they can, but it's not a perfect system. And they can have bags with tubes for time specimens. And you know what else is really slick for these little bags, and a lot of nurses haven't thought of this? Sometimes a baby will come in, like a pretty small baby, maybe 6-8 months old, and they have a raging case of diarrhea, and it might be rotavirus or something like that, where the second the kid goes, it absorbs into the diaper, like it's that runny. So what I tell the nurse to do is take one of these and put it on the baby's rectum, and as they're crying or whatever, it will collect stool in that bag, which is another slick way. So it's a little trick that some of us lab people have up their sleeve for those nurses that are like, oh my gosh, how do I collect this? It just soaks in the diaper. Use one of these. You'll thank me later. Drug specimen collection is a little bit different. This involves proper collection, label, and handling is documented. There's a chain of custody. So the person who collects the urine along with the patient sign sometimes the urine cup over a sticker that goes over the top and the form It needs to be free of substitution, adulteration, or dilution. So there's a lot of things that we check on with this. A specimen must withstand legal scrutiny, so you could end up on the stand with these. You have to have a photo ID of the patient. Sometimes it has to be witnessed. So depending on what's ordered, sometimes you have to stand and watch the patient go and collect it. Other times you don't. We check the temperature of the urine. It needs to be between 32 and 37 degrees within 4 minutes of collection, and there's always these little temperature strips on it. Report temperatures outside a range, because a lot of times that's rejection issue. Inspect the urine color for anything unusual. If it's crystal clear, it could mean that they added water to it. In a lot of cases, they shut the water off and they turn the toilet water blue. So if they were to try and use the sink or scoop the urine out of the toilet, it would be all blue or it would be crystal clear. So we have ways of knowing for that. So that concludes our PowerPoint on introduction to urine. In the next couple weeks here, we're going to start doing some urinalysis testing.